Aikaji.
Yeah.
So,
Yeah. So
okay. So after these wonderful presentations from my esteemed speakers, we like to move to the next part, which is the panel discussion. And I'd like to invite the panelists for today evening. Um, do we have Dr. Chaturbuj Agarwal here? Dr. Chaturbuj, have you joined, sir? Dr. Chaturbuj, Dr. Sameer Khatri. Dr. Chaturbuj is considered medical oncologist at RGCI New Delhi. Dr. Sameer Khatri is my senior and Director and HOD at Department of Medical Oncology, Shanti Mukund Hospital, New Delhi. Dr. Sajjan Gupta, if we could have, yeah, I'll request that panelists to put their mic on and also, if possible, camera. Dr. Sajjan Gupta is considered medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And Dr. Kishore Kumar Kota, he is assistant professor medical oncology at TMC Muzaffarpur. So, do we have all the panelists before we start? And can we also put the presentation from your side, the organizers?
good evening, sir. Sir, Dr. Sameer sir and Dr. Tarjan sir is joining in few minutes.
Okay, okay. So we'll start the presentation because I think we're slightly ahead of the time. So like 5 to 10 minutes. So should we just request them? They will start joining in. So before that, I'll start having some conversation with my panelists here. So can we start the case? Once other panelists join, then we could involve them in the case. Okay. So this case is 55-year-old lady. She's T4N2M0 clinically, ER negative, PR negative, HER2 3+ by immunohistochemistry. Next slide. Okay. I'll start with Dr. Chaturbuj. Dr. Chaturbuj, with such a clinically evident patient, first is that what do you do to stage, and how do you decide when you will start neoadjuvant chemotherapy in your patients who are ER/PR negative, HER2 3+? Dr. Chaturbuj. So Chaturbuj, I guess you are on mute. You have two ways by which you are joined. Could you log in from one? I can see you in one of the channel, and another one I can only see your name. I can't hear you.
Sir, Sameer sir has joined.
Okay. Welcome, Sameer sir, and we just begin with the panel discussion. So,
Sajjan, hi.
Hello, sir. So, can we just go back to the last slide? I'm also not able to hear Dr. Chaturbuj very clearly because he was trying to say something, but I couldn't hear him. So, we're discussing HER2 positive breast cancer and the different scenarios. We start with the first case, which is 55-year-old lady, clinically T4N2M0, ER negative, PR negative, HER2 3+ by ISC. So I started with Dr. Chaturbuj. Dr. Chaturbuj, could you answer the first question? Like I said, when do you decide you will take such patients for neoadjuvant chemotherapy? How do you take treatment decisions in HER2 positive breast cancers in 2021? Okay, so Dr. Chaturbuj will join from other device. Dr. Kishore, till the time, I like you to answer this question.
Yeah, sure. In this case, first we have to stage the patient. I have two options to stage the patient. One, we can do, one is ultrasound abdomen, the most common sites to exclude the metastasis. One ultrasound abdomen, I want to exclude the liver metastasis, and I will prefer bone scan to exclude the bone metastasis, and chest X-ray to exclude the lung metastasis. And there is another option for me also, which I can prefer, is PET scan. I can exclude at a time all sites of disease. I can exclude bone, liver, lung, all at a point of time. If patient is affordable, I will go ahead with PET scan. If patient is not affordable, then I will go ahead with ultrasound abdomen and bone scan and chest X-ray. First, in this case, I want to exclude the metastatic disease. And then if there are no mets, now coming to the therapy wise T4 and 2. In this case, I want to give initially neoadjuvant chemotherapy.
Okay. Dr. Sameer, sir, which are the patients, because nowadays there's a lot of buzz with the neoadjuvant chemotherapy or chemoimmunotherapy, HER2 positive breast cancer. So which are the patients which you actually discuss with your surgeons and decide that even if they are operable, you're more happy to give them neoadjuvant chemotherapy? So where is that you draw a line that this is the patient you should take for upfront surgery, and this is the patient you should send to me, or we should start with the neoadjuvant chemoimmunotherapy?
So what has been our practice now with new data and all and dual blockage, and we are doing a neoadjuvant for everyone above T2, T2 and above. We are doing a neoadjuvant for all, as you might be discussing also the importance of pathological CR. So, and how pathological CR is important for disease-free survival and overall survival maybe. So what we are doing at our institute now is T2 and above. We are giving to all the patients the neoadjuvant, and if patient can afford, then dual blockage.
So I agree with you, sir. In fact, there's a new data which shows even tumors which are centimeter, more than 3 centimeters of tumor, which are even still T2. Even such patients, if they are not positive at T2N1, we're still going at, especially the size of tumor is more than 3 centimeters. There's a lot of emerging data which shows that such patients can also benefit with
even T1C. Yeah, definitely.
Okay, sir. Next slide, please. So with the various guidelines are there, like sir said, the initial guidelines have been like, if you just see the NCCN guidelines have said inoperable breast cancer is it's a N2 disease or N3 or T4. So these are the inoperable breast cancers. Operable breast cancers are which HER2 positive with triple negative, T2 or higher, or N1 or higher. These are the patients which where you might use neoadjuvant chemotherapy. So same guidelines also has said that it should be preferred approach in the stage 2 or stage 3 HER2 expressing or triple negative breast cancer. So in both these settings, most of the guidelines are suggesting that neoadjuvant approach might be better, even if the patient is T2 or N1. So these patients might be taken up, especially even T2, they are more than 3 centimeters. There's data which shows that they might benefit from neoadjuvant chemotherapy. Next slide.
Sir, good evening. So I am back, and my device was not working. Sorry for the inconvenience.
Fine.
Sir, can I ask one question in the other way around? So we all say that now HER2 positive, we should use neoadjuvant therapy. So if we ask the other way around, maybe you or Samir can answer. Is there any subset of patient HER2 positive where we can directly go for surgery? Means which subset of patient you will prefer upfront surgery?
So I think Dr. Samir is the most senior one among us, and
maybe less than T1A and B, we can go in for surgery, and 1 or 2 patients are like this only, though they land up with surgeon and they operate also. And at times, though it's not there always, but at times they don't wait for ERP or HER2 report also, and they do the surgery also. So these are the type of patients who undergo upfront surgery in HER2. We always say to our surgeons, go in for neoadjuvant. There is ample data now for neoadjuvant that favors neoadjuvant therapy. But few patients do land up with surgeons and they do surgery. And at times they land up in non-onco centers also. And especially these type of patients, I am catering to many of these patients, and we give them adjuvant only then. So apart from that, T1C, as Sajjan said rightly, more than 3 centimeters, all patients should receive neoadjuvant. So,
so you have a very strong breast cancer tumor board. So do you see this practice evolving in Rajiv Gandhi, like with the more data emerging, especially in HER2 positive or TNBC towards neoadjuvant? So are the surgeons really willing to give these patients to you before they put a knife on them? So what is your take on the patients you're seeing over the last 2-3 years? Because such meetings, they're also involving many of the surgeons. Unfortunately, we don't have any surgeon into a meeting, but then the data shows that like many other malignancies, like we moved in esophagus, in sarcomas, in rectum, we moved towards neoadjuvant and then going for definitive surgery. So you see a change in your surgical colleagues at Rajiv Gandhi over the last 2 years?
Yes, sir. So, sir, one submission actually since last 1 week I have left Rajiv Gandhi. Now I am not in Delhi.
Where are you now?
Sir, I have moved to Middle East. I am in Bahrain.
Good.
Dr. Sameer will plan his next meeting in Bahrain.
Yeah.
We now have a sponsor in Bahrain.
चलते हैं Bahrain में. हाँ.
So
तो हमारे
we are looking forward to see you in Bahrain.
Yes, sir.
Okay, before you left.
But before I left, sir, there was definitely a change in practice. Means now at least all node positive patients, they are coming for upfront neoadjuvant chemotherapy. But as Sameer so rightly told, what practically is happening is if the patient goes to surgeon first, then there is no chance. Means node negative tumor, definitely nobody will send for neoadjuvant therapy. But yes, more than 3 centimeter tumor should receive neoadjuvant therapy. But you asked me, so things are definitely changing.
Yeah.
Now we have a competition also between surgeons. There are 2 surgeons, so they have 2 surgeons.
Okay, now things have become more competitive. And just to ask out of curiosity, is Dr. Akhil Jain also there in Bahrain or he's not there?
No, he's in US.
अच्छा, Dr. Akhil Jain is in US. Okay.
But Bahrain में भी तो है ना एक medical oncologist from India.
हाँ है, एक है डॉक्टर चतुर्भुज अग्रवाल है सर वहाँ पे.
अरे वो तो अभी आए हैं, अब तो छा जाएंगे बिल्कुल. Very good. Good.
So today we are lucky to have international faculty in our.
Yes, now we have international faculty. Good.
Thank you. Acha, okay. So we move ahead. I can see some of my other panelists. Dr. Tarachan, I'm able to see him over the bridge, but only bridge is visible. Dr. Tarachan, yeah, can you? Dr. Tarachan?
Yes, yes, I am there. Yeah, Dr. Tarachan.
Okay, welcome, yeah. Okay, can we move the next slide? Then I'll ask a question, Dr. Tarachan. Yeah. Okay. So I think this is we've been already discussing. Can we go to the next slide? So I think we all know that now the gambit of neoadjuvant is actually evolving, and we are having more and more patients in breast cancer for neoadjuvant chemotherapy. So given a choice, HER2 positive patient, what would be your preferred choice? Dr. Tarachan, what would be your preferred choice?
Yeah, I will go with the TCHP.
Okay.
As per the neosphere, I will prefer the TCHP as a neoadjuvant chemotherapy.
TCHP is your choice. Dr. Kishore, TCHP or any other regimen, and why?
We are preferring here, most of the patients are not affordable, but most commonly we are using weekly Paclitaxel plus trastuzumab and for them followed by AC.
Okay. So I assume that you're working in a sector where probably pertuzumab is not easily available. So if pertuzumab is not available, so yes, I agree with you. You could have a combination of trastuzumab with taxanes or add carboplatin, or you could also have a combination like AC followed by AC followed by taxane plus trastuzumab. So which could have a fair, I would say, pathological complete response. So coming to Dr. Chaturbhuj, I know Bahrain everybody can afford everything, but yes, if finances are an issue, would you prefer anthracyclines to be a part of the regimen, or you still not like anthracycline and you only go for anthracycline-free trastuzumab based combination?
No, sir. So I think TCHP would be the preferable choice. If patient cannot afford pertuzumab and if it is node positive, then I would like to go with AC followed by TH, which will be more preferable than TCH.
So yes, in case because there was some data where probably some of these patients had topoisomerase 2 overexpression also, which had benefit of adding anthracyclines. But yes, with the evolution of TCHP, many of us have now moved away from anthracycline containing regimens in our patients. So affordability is not an issue. TCHP has become another favored regimen for most of the oncologists. Dr. Sameer, sir, any thought or any difference of opinion?
Again, no, I am using TCHP, but there is some thought when node positive is there and maybe a role of anthracycline is there. There was some trial was there which was showing. But we are now very comfortable with TCHP. And if patient cannot afford, then 4AC followed by Taxol and trastuzumab.
So I think all the panelists agree with what there's a consensus among the panelists. Next slide, please. Next slide. So I think we already discussed this will skip. Next slide, please. Next slide. Next slide. We already shared these files with our So this patient underwent AC4 followed by TH12, underwent MRM, was found to have YP, T2, N1. There were 3 lymph nodes which were positive. Now coming to adjuvant setting. So Dr. Tarachan, in your settings with residual disease, what is your current practice?
Yeah, so if I have given a TCHP or any other anti-HER2 therapy in neoadjuvant setting, and there is a residual disease after the neoadjuvant setting chemotherapy, then I will go with the KATHERINE trial and give the TDM1 for the 14 cycles remaining.
So here the P was not given. So does it make any difference, or you still go with the KATHERINE data, which P not being given the neoadjuvant setting? Because now we have some generic.
No, there is no. Any anti-HER2 therapy, if it has been given, and there is no path CR after the neoadjuvant, then TDM1 is the right choice.
Okay, Dr. Chaturvedi, your take on such patients?
Only 20% of patients in KATHERINE they received pertuzumab. Rest all the patients they have received only trastuzumab. So definitely, if patient can afford, TDM1 is the right choice.
Okay. Okay. Dr. Sameer, sir.
Yeah, I agree. So in fact, both if dual or single trastuzumab or dual blockage was there, so numerically dual blockage they did better with TDM1 in fact. So but even if trastuzumab is given, then also TDM1. So as Chaturvedi rightly said, 80% only received trastuzumab.
So, okay.
Patient should receive TDM1.
I have a question. Can I ask?
Yeah. Go ahead. Yeah,
Sir, if patients received paclitaxel plus trastuzumab weekly, 12 weeks, and then he underwent surgery, then residual disease is there, then what about the role of TDM1?
The role of TDM1. Okay.
Yes, 12 cycles of PPLHS she received, and then she underwent surgery, and then residual disease came positive.
Yeah, it was a weekly regimen.
Then AC was given. Then what about TDM1?
Yeah, it was a weekly regimen. So actually, effectively, there were only 4 cycles of this was given. It was a weekly schedule.
Patient should receive 14 cycles of 14 cycles of TDM1 as per the KATHERINE trial, plus radiation, of course. Radiation should.
With AC, with first surgery, then followed by AC, and then followed by TDM.
He wanted to ask that patient has not received any anthracycline. Patient has received only taxane and trastuzumab,
Yes.
Okay.
and then surgery, and then there is residual disease. So will it?
And then residual disease. Yes.
This is what he wanted to ask.
Okay.
Yes.
So if the patient has not
Yes.
been
Yes.
exposed
Yes.
to, for example, the patient was exposed to TCH. For example, we have patients who have been exposed to TCH only. So no anthracycline exposure. So Dr. Chaturvedi, what is your take in such patients?
So again, I think, sir, we have sufficient data. Anthracycline, if patient has not received, then also we can offer TDM1 because patient has already received taxane. As you only told that there are anthracycline-free regimen also in KATHERINE.
Yeah. So I think the evolution of these the KATHERINE, actually the principle behind KATHERINE was whether a residual disease could have a more impact by using a TDM1 instead of having dual blockage or only a blockage which will only have immunotherapy there, because most of such patients would have received chemotherapy and they would have ended with their chemotherapy, and so the TDM1 brings in chemoimmunotherapy for 14 cycles, and that probably adds to more of this distant metastasis free survival in such patients. So that yes, the regimens, if they were used TCHP, probably the initial pathological response was very high compared to using a dual blockage in the first line setting, where the pathological response rates are less than 40 or 45%. Next slide, please. Next slide. Next slide. So with this, we already discussed. Next slide, please. So we've already discussed alone versus TDM1. I think the other option is now the patient is able to afford pertuzumab. For example, the patient gets funding from the government. So would you still consider, instead of TDM1, would you consider trastuzumab plus pertuzumab as 14 cycles? Is there a patient, or you will still prefer TDM1? Dr. Chaturbuj, any thought on this?
No, sir, I think we will prefer TDM1 only. Patient can afford, so TDM1 is the standard of care as of now, whatever data we have. So we have affinity data, but it has shown only 1.2% benefit with addition of pertuzumab, even in ERPR negative subset also. So I don't find any place of pertuzumab in adjoint setting. As far as TDM.
Yeah, Dr. Tajan, the other option, trastuzumab plus neratinib, if that was available to us.
No, I will agree with Dr. Chaturbuj. Then as of now, the TDM1 is the standard of care as an adjuvant setting if the finances are not a constraint.
Okay. So all the panelists, I'd say they agree. If their finances are not an issue, they would like to use TDM1 as their adjuvant, especially in patients who have residual disease, based upon the KATHERINE data, which shows there's a significant difference in the distant failure-free survival and also trends towards improvement. Though the data is not mature, but then probably there might be some benefit in the OS also in the later when we have more 10 years data. Right now we don't have any OS difference, but yes, distant metastasis-free survival, there is a huge difference. Next slide. So we just saw this. So invasive disease-free survival 88.3% versus 77% at 3 years. That was really remarkable. The number of events were almost double in the only trastuzumab arm compared to Kadcyla, which was 91, whereas 165. The hazard ratio was 0.50, and this is something really, I would say, practice changing. And this is what has actually led us to believe and use more of TDM1 in the adjuvant setting. Next slide. So I think similar question with the patient used. We had a lot of chemotherapy. We had FEC3, THP, and what then? Even after that, what would be your preferred post-op regimen? So in one word, you could just answer, Dr. Chaturbuj. HPH TDM1.
So, but patient has same post-op findings. So I think TDM1 again.
TDM1.
Okay. Dr. Tarachan, any difference in such patients?
Yeah, TDM1 is the right choice if the there is residual disease.
Okay. Sameer sir, any difference?
No, TDM1. Yeah.
Okay. And Dr. Kishore, any thoughts? Any
yes, no, TDM1, sir, TDM1.
So all the panelists agree that even whatever the pre-op regimen was there, if there's a residual disease and people have now developed trust over TDM1 for their patients in the adjuvant setting if the residual disease is there. Next slide. So I'm just skipping this because repetition of these things. Next slide, please. Next slide. I'll just skip this because none of us, I think, are considering neratinib. If any of you would like to comment, any of you would like to comment neratinib?
International faculty शायद कुछ comment कर ले.
No, sir. Even if you consider neratinib, it is not available. It is not available here also.
अच्छा, वो डायरिया में ही बैठा रहेगा बेचारा.
80% diarrhea rates.
95%. 90% diarrhea.
90% diarrhea, yeah. Okay.
Yeah, and there is now talk of giving prophylactic loperamide for that.
I think this drug did not really pick up well in being there in the market for more than I think a decade, but has not been able to have any mark. Yeah, next slide, please. Next slide. So this patient received TDM1 for 14 cycles. Patient at 8 months had headache. MRI brain showed single cerebellar metastasis. SBRT versus whole brain versus surgery. Just a quick take by my panelist, Dr. Chaturbuj. Single solitary metastasis in cerebellum. SBRT, whole brain RT versus surgery.
So, sir, I think I would prefer surgery because it's a single lesion. The benefit of surgery over SBRT is simple, that we can again get a IHC and again know the nature of the disease.
Okay. So, the Dr. Sameer, your preference for single solitary metastasis, especially resectable in the brain. You go for surgery or you go for SBRT?
So if it's really operable, then surgery. But I hardly see any surgery done for that. So SBRT.
Because we don't get
only
it.
If it is a solitary site. So maybe.
Because
I have one patient.
Yeah. Many times,
So
sir, as
that-
medical officers, we are also not sending references to our neurosurgeon. I know there's some which we are more happier.
At times they land up with neurosurgeon only.
So, Dr. Tarachan, at your center, your surgeons are happier, or you are happier?
Yeah, usually patient after the completion of treatment, whenever has a headache, they usually visit the neurologist and then the neurosurgeon, and then patient comes after the getting surgery done. So
Exactly.
I think this is the right choice, and patient already has decided the best treatment.
Okay. So yes, I think the data shows
once the patient visits the neurosurgeon, then our headache starts.
Are you able to dodge the neurosurgeon, or you give it to the neurosurgeon?
हमें टिश्यू मिल जाता है, टिश्यू के साथ में कुछ और आ जाएगा.
Okay. So next slide, please. Next slide. So like, though they are not my slides, but yes, the patient underwent SBRT, and post SBRT, the patient had leptomeningeal enhancement, CSF cytology was positive. Really bad things happening for this patient quite soon, early on. This is not a typical case. I would not say that these are typical cases, because yes, most of the patients do well when we are doing them HER2 blockage, and they don't end up failing so soon. But yes, this patient did really bad. Next slide. Now coming to the next question. Such patients landing up with early failure in the brain, despite your local control in the brain. So among these choices, Dr. Chaturbuj.
Tucatinib, capecitabine, trastuzumab, based upon HER2 claim, 66% CNS response rate. I think that should be the first choice.
Okay. Dr. Tarachan?
I think I will differ from Chaturbuj here, that I think Tucatinib is in third line or beyond. At present, it has not come in the first line, and patient has already the more than 6 months of the progression-free survival. So theoretically, we can re-challenge with the Cleopatra regimen, but still I would go with the different drugs which have not been used, that is the lapatinib plus capecitabine, with the intrathecal trastuzumab can be given in the positive CSF cytology.
So your choice is intrathecal trastuzumab and lap and cape. So Dr. Sameer, your take.
Yeah, again, this patient is not doing well, so survival is not very good. I will go in for Tucatinib, capecitabine, and trastuzumab, and I have no experience of intrathecal trastuzumab.
Okay.
Heard a lot about that, so maybe I will like to try.
Chaturbuj, what about Tucatinib? Because I don't have any experience. You have any experience with Tucatinib? We didn't have any experience with Tucatinib.
No, sir. We have not given to any patients Tucatinib, but intrathecal trastuzumab we have given to 2 patients.
Okay.
So one patient did good.
So was it the normal trastuzumab which we use in our practice, or it was something different?
No. It actually, ideally, it is supposed to be different trastuzumab. But since we don't have the trastuzumab, so we were giving normal trastuzumab, because we actually consulted Dr. Jyoti Wadhwa ma'am. Dr. Jyoti Bajpayee ma'am. She has actually given to 3 patients. So it was already published from TMH. Okay. So there was one patient. I am sure, sir, you must have seen that patient. She's an old patient. She was professor. She was an old patient. You must have seen her in.
Yeah, Dr. Kishore, any difference?
No, I will prefer capecitabine, lapatinib, and Tucatinib. We never. I have no experience with Tucatinib, and I not have experience with intrathecal trastuzumab also.
I think intrathecal will be really good, because now they're coming up with you're very surprised, they're coming with a combination of Trastu plus pertuzumab subcutaneous also. So so I think things will become better with these small depot preparations coming up for especially these monoclonal antibodies. Things might be definitely better. I don't know if they are able to give them intrathecally, how would they respond? But short of that, yes, if Tucatinib is available anywhere, this could be tried. But yeah, Dr. Achan, you want to say something?
Yeah, just I think I am firm with the decision. Hello?
Dr. Achan, there is a lot of movement on you're all over the bridge.
Yeah. This is the benefit of the webinar. No? Yeah. You can do this from anywhere.
Yeah. Okay. Okay.
So you can see that the Earth is moving. No? I am proving that the Earth is still moving.
Yeah. A lot of movement. It appears like you are just going to reach the sun. Okay. Okay. So I think all the panelists agree that yes, we have certain combination which we can use based upon our own clinical judgment as well as our practical experience with these drugs. But most of the patients end up having lapatinib plus capecitabine as clinical practice, especially if they are not benefiting with PD-1 or trastuzumab or pertuzumab. But yes, we could have these drugs. Next slide, please. Next slide. I don't know. This was a similar patient who would have developed same. I would just yeah. Next slide. So this has already been discussed. So if the patient has got a candidate who is a CT2 or clinically node 1, we could go for TCHP or AC followed by THP, and residual disease there. TDM for 14 cycles. Neoretinal is still a question mark. If there's the disease is pathologically complete response, we could go for H plus minus P in most of our patients, or H plus P. Next slide. So now this is another case. 40-year-old lady presented with severe backache. She was found to have locally advanced breast cancer with extensive bone mets and lung metastasis. So clinically it was T4D NC M1. It was ER positive, PR positive, HER2 3+. Next slide. Next slide. So the first question, Dr. Chaturbuj, do you have a baseline imaging for brain for all your HER2 positive MBC patients?
No, sir. So we do brain imaging for breast only if the patient is symptomatic, for if there are some symptoms and we are suspecting.
Okay. Dr. Sameer, brain imaging is a part of your staging workup? Or
we are getting it done now. We are getting it done. For past 1 or 2 years, I have burned my fingers in a wrong way. So we are doing it regularly now.
Okay. Dr.
Just 2,500 rupees. Why to unnecessary?
No, sir. We are not doing. If patient is symptomatic, then only I am doing. Or else we are not doing.
Okay. Dr. Gupta?
20-30% will be asymptomatic.
Yes, if the patients are symptomatic, then we are doing MRI brain, otherwise not.
So the panelists have a disagreement here, and I think some of the panelists say I'll get it done, others are saying okay. And what do we do for asymptomatic brain mets? Do we start, like, we observe them more closely? Dr. Sameer, but if the patient is found to have some
prognostic wise, so of the things.
Okay. Next slide. Next slide. Next slide. Next slide. I think we just skip it here. Next slide. So for metastatic patients, how do you what is your combination? What is the preferred combination, Dr. Chaturbuj? And how does it depend upon the patient's performance status or some other parameters in metastatic setting? Triple positive breast cancer. What is your choice? Triple positive.
So, sir, one thing, just last, you asked Sameer, sir, that if the patient has asymptomatic brain mets, then what will you do, radiation or chemotherapy? So we have to look at the systemic bulk of the disease. If the patient has a lot of systemic bulk and the brain metastasis is single and asymptomatic, we can avoid addressing it. We can start with systemic therapy. So now coming to systemic therapy, obviously taxane plus trastuzumab is the treatment of choice in all patients, with addition of pertuzumab if the patient can afford. But sometimes if the patient is frail, the disease bulk is very much high, then I would sort of avoid pertuzumab in the first cycle. We would just give trastuzumab and taxane, and we will add pertuzumab from the next cycle if the systemic bulk is very high. But in this patient, I would definitely prefer THP for 6 cycles.
Dr. Sameer, for triple positive breast cancer, always chemotherapy as an addition, or you use AI, or for example, this is a premenopausal lady, so ovarian ablation along with your hormonal treatment along with the HER2 blockage, or chemotherapy?
But we are doing always HER2 blockage first.
No, HER2 blockage is fine. We are doing, but chemo or hormone?
Along with chemo. Along with chemo.
Okay. So, Dr. Tarachand, if the patient was supposedly, for example, 70 triple positive. What would be your choice? Do you always?
So you, you want to avoid trickily chemotherapy. So we will avoid also in the elderly people. If the patient is not fit for the chemotherapy, then we can give a trastuzumab plus the AI alone. If the patient is fit for the chemotherapy, then we can go with the THP of the 6 cycles followed by TH plus AI.
So what about GnRH analog, sir, upfront along with THP? Your opinion, if hormone positive in premenopausal?
Yeah, so I think Chaturbuj can answer. Chaturbuj was the leader of the best clinic at Rajiv Gandhi. He has a lot of experience. He has more experience than many of us here.
Oh, so my apologies, sir. You are left with just 5 minutes to conclude the panel discussion. Thank you.
Don't be apologetic. We are very happy.
Okay.
Okay.
So he was asking, sir.
Yeah.
So he was asking only trastuzumab, pertuzumab, and hormone.
Yeah. So
premenopausal, hormone positive, HER2 positive, metastatic, and I am giving THP. Now my question is whether what about your opinion on GnRH analog along with that first cycle of chemotherapy? We will give hormonal therapy after completion of chemotherapy with trastuzumab. My question is, what about adding GnRH analog with THP?
I think there is no role of adding GnRH analog with chemotherapy, because anyway, when we are giving chemotherapy, the ovarian functions are going to suppress automatically. GnRH with chemotherapy is given only in triple negative breast cancer when we want to give a chance of fertility preservation. Otherwise, I don't think there is any point in giving GnRH analog.
Okay. So, yes. Any difference of thought? Any difference, Dr. Sameer? Would you like to comment something or add something here?
No, it's absolutely fine.
Okay.
While giving chemotherapy, why to give GnRH analogs?
Okay.
So only after finishing the thing, and
so actually, unfortunately, I'm having a very bad day with the patients here today, because this lady also after 7 cycles has started having blurring of vision. I know which case are they giving me today from the sponsors.
You start.
So again having extensive leptomeningeal and brain metastasis. So Chaturbuj, I will refer such patients to you, even if you are in Bahrain. I will not be happy. I will not be happy.
Tocatinib dega wo. We'll start giving tocatinib to that.
Okay.
Ideal patient for tocatinib now.
So next slide. So I think in the we are right bang on time. So I like to really stop it here, and we've been actually having this panel discussion for more than 40 minutes, and it's because our lecture started fast, and then we are about to finish at 8:30 was our time. So with this, I like to thank all my panelists for such lovely interaction, and Chaturbuj, really happy to see you representing Rajiv Gandhi as well as making us proud in the foreign land, and we hope that you have a great career there. And Dr. Sameer is always smiling because he like to visit the country Bahrain, and we request you that very soon you have a international meeting there, sir.
अब सज्जन के साथ ही चलेंगे भैया. हाँ, जैसे सिंगापुर गए थे, याद है? हम यहाँ चलेंगे. Definitely.
को भी लेके चलना हमने.
बुलाएगा तो.
पुल पे तैयार है हम.
Definitely, sir.
Chalo, good, yaar, good.
Dr. Kishore and Dr. Sajjan, thank you again, and thank you all of you for joining us for this lovely meeting here. And I'm sending this back to the organizers, and over to Ekta ji.
Thank you for the lovely discussions, and good night, everyone.
Okay, bye-bye.
Close our meeting. Bye-bye, everyone. Bye-bye.
Before you say good night, I'd like to thank you.
Can we go offline?
Ma'am,
नहीं हो गया. Thank you हो गया भैया.
Thank you हो गया. Okay जी, thank you. So are we offline?
Yes.
Thank you, ma'am. Thank you so much.
Thank you. Welcome, sir. Welcome, everyone. Happy to help you.
Thank you so much, ma'am. And thank you all the team members for this meeting. Okay.
Thank you, Aram. Thank you, Pooja.
And thank you for Roche for